Acute and chronic pancreatitis. This picture is demonstrating the organs of the biliary system and the pancreatic ducts. The concepts that we'll be looking at in this module are going to be nutrition and immunity, with the nutrition exemplar being cholecystitis and the immunity exemplar being acute pancreatitis. The interrelated concept in this chapter will be comfort. So with acute pancreatitis, we need to first of all look at the pancreas. The pancreas is an endocrine gland that secretes insulin, and it's an exocrine gland that secretes enzymes that will become active in the small intestine to assist in the breakdown of starches, proteins, and fats. Now, if those pancreatic enzymes activate early, such as in the pancreas, we're going to have the development of the inflammatory process of pancreatitis. So with acute pancreatitis, this is a serious and potentially life-threatening inflammation of the pancreas. Again, premature activation of excessive pancreatic enzymes will start to destroy the ductal tissue and the pancreatic cells and will result in autodigestion and fibrosis of the pancreas. Pancreatitis can be mild with just edema and inflammation to severe with necrotizing hemorrhagic pancreatitis, or NHP. And that is basically diffuse bleeding pancreatic tissue with fibrosis and tissue death. A chart of the autodigestive process will be found later in the slides. Complications of acute pancreatitis can be severe and life-threatening. They include hypovolemia, hemorrhage, acute kidney failure, paralytic ileus, hypovolemia or septic shock, pleural effusion, respiratory distress syndrome, ARDS, or pneumonia, multisystem organ failure, and disseminated intravascular coagulation, DIC, in addition to diabetes mellitus. So we need to recognize cues, and as we recognize cues, it's also important to understand what potential causes of acute pancreatitis can be. They can be trauma, and this would be from blunt trauma, gunshot, or stab wound. It might be from obstruction, from cysts, tumors, or abscesses. It might be a metabolic issue, such as hyperlipidemia, hyperparathyroidism, and hypercalcemia. It might be renal failure or transplant, gastric or duodenal ulcers, viral infections, alcoholism, which is more common in men. Pancreatitis would be more common in men with alcoholism, drug toxicity, smoking or tobacco use, cystic fibrosis, gallstones, which will account for almost 1/2 of the obstructive pancreatitis, and that situation would be more common in women, and family history. So with our assessment, we need to notice and observe what's going on with our client. The signs and symptoms we might see would be severe and constant abdominal pain to mid-epigastric area or the left upper quadrant. It can radiate to the back, the left flank, or the left shoulder. Usually has a sudden onset, and it will be worse if the client is in the supine position. And the client will probably find relief if they lie in the fetal position or they sit upright and lean forward. It is important to determine what triggers may have caused this pancreatitis, such as alcohol intake or maybe a high-fat meal. These clients often experience weight loss, nausea, vomiting, jaundice, a gray-blue discoloration of the abdomen, periumbilical area, and/or the flank. They may also have decreased or absent bowel sounds, abdominal tenderness and/or rigidity, which would be a sign of peritonitis, ascites, elevated temperature, tachycardia, decreased blood pressure, and they may also have dyspnea or orthopnea. With the psychosocial assessment, it is important to determine what their alcohol intake history is. The labs that we'll be looking at would be amylase, lipase, trypsin, elastase, glucose, calcium, magnesium, leukocytes, the C-reactive protein. With liver involvement, we would also look at the bilirubin, the alanine aminotransferase, or the ALT, or the aspartate aminotransferase, the AST. With imaging, we could use the ultrasound, and that would help us determine the cause, such as gallstones. We could use a contrast enhanced CT scan to help with the diagnoses. Abdominal x-rays would also potentially show gallstones. Excuse me. A chest x-ray could show the elevation of the diaphragm or potentially a pleural effusion. And we could do an ERCP, which is endoscopic retrograde cholangiopancreatography, and that would show us pancreatic stones. Prognosis with acute pancreatitis: early treatment has decreased mortality. If the cause of the pancreatitis is from a biliary tract disease, the prognosis is usually pretty good. If it's from alcoholism, it is often pretty poor. With acute pancreatitis, we're looking at this picture here in the slide, and it's demonstrating a peripancreatic stranding, which is a finding of pancreatitis. There are also multiple gallstones in the gallbladder, and this was the cause of this client's pancreatitis. The priority collaborative problems for clients with acute pancreatitis include acute pain due to that pancreatic inflammation and enzyme leakage, that autodigestion of the pancreas, and weight loss due to the client's inability to ingest food, and if they are able to ingest food, to absorb nutrients. This slide is showing us the process of autodigestion in acute pancreatitis. So now we need to begin our planning and implementation. First of all, we need to manage pain. That's going to be one of our primary things. We can treat this pancreatitis non-surgically with intravenous fluids. These would be isotonic. The client should be NPO while they are in an acute status. The primary drug class that we would use for analgesics would be opioid. Potentially, we would replace calcium and magnesium. The client may require an indwelling urinary catheter so we can obtain accurate I's and O's, and an NG tube. We also need to promote nutrition, and this would require potentially antiemetics with nausea, vomiting, jejunal tube feedings. Enteral feedings are preferred over parenteral because of a decreased complication. We would need to do daily weights. If the client is not NPO, the client should have small, frequent, moderate to high carbohydrates, high protein, and low fat meals. It should be bland, in other words, not much spice. And the client should also avoid caffeine and alcohol. These clients may also require supplements, whether they're in a pill form or liquid form. With the care coordination and transition, this is basically looking at management for home care and teaching the client how to self-manage. And of course, after we do any interventions, the nurse needs to evaluate. Did what we do work? And if not, what do I need to do differently? With chronic pancreatitis, this is a progressive destructive disease of the pancreas. It is characterized by remissions and exacerbations. We're going to see inflammation and fibrosis that leads to pancreatic insufficiency and diminished function of the pancreas. There are different classifications. It can be chronic calcifying pancreatitis, which is the most common. It can be chronic obstructive pancreatitis. This comes from spasms and or obstruction of the sphincter of Oddi, which is shown here in this picture. It's also in your textbook. And that could be from gallstones. It may also be autoimmune pancreatitis, which increases the risk of pancreatic cancer, along with idiopathic and hereditary chronic pancreatitis, which also increase the risk of pancreatic cancer. Excuse me. These clients are going to have, with the loss of exocrine function, steatorrhea, which are going to be pale, bulky, frothy, very odorous stools that contain a lot of fat. They'll have weight loss, muscle wasting, fat and protein malabsorption, loss of endocrine function. We're going to have diabetes mellitus. We may also see pulmonary complications such as pleuritic pain, pleural effusions, pulmonary infiltrates, ARDS, the acute respiratory distress syndrome. We can see pancreatic ascites, definitely pain, jaundice, dark urine, and the diabetes mellitus symptoms, those three Ps: polyphagia, polydipsia, and polyuria. To treat it non-surgically, the primary interventions are going to be drug and nutrition therapy. That will require analgesics, enzyme replacement, and insulin therapy. With nutrition, that would be our total parenteral nutrition or total enteral nutrition, vitamin and mineral supplements, a consult from the dietitian, because these clients, in order to maintain their weight, are going to require 4,000 to 6,000 calories a day. They will need high carbs and high protein, but they need to avoid high fat. Surgically, we don't really do this for chronic pancreatitis except in cases of ongoing abdominal pain, pancreatic abscess or pancreatic pseudocyst, or if the need for a cholecystectomy is required. So let's look at a case study. We have a client presenting to the emergency department the day after Thanksgiving. The client states that about 1 hour ago, he experienced a sudden onset of pain in the left upper quadrant that radiates to the left flank area. The client rates the pain as an 8 on a 1 to 10 scale, or 0 to 10. The client is admitted with acute pancreatitis. So, which lab finding corroborates with the diagnosis of acute pancreatitis? Serum lipase of 150, serum amylase of 200, serum glucose of 80, a WBC of 6,000. This would be our serum amylase. In preparing to care for the client, which condition does the nurse recognize as potential complications of acute pancreatitis? Select all that apply. Strep throat, no, that's not a complication. But pleural effusion, diabetes mellitus, pancreatic infection, and acute kidney failure are. When the client is asked about pain, the client states that it's intense and continuous, and states that sometimes when he curls up in a fetal position, the pain decreases. Which medication does the nurse anticipate that will be provided or that will provide the most comprehensive pain relief at this time? Well, as you look at these, we can pretty well rule out ibuprofen and acetaminophen. As stated earlier, we're probably going to be administering the opioids. So now the question is do we administer it orally or do we administer it intravenously through the PCA? In this case, the PCA is probably going to be more effective. The client has been NPO but is now tolerating food. What education will the nurse provide regarding nutrition? Do we do small frequent meals? Do we use alcohol and caffeine to be consumed in moderation? Would we expect to experience nausea, vomiting as the client begins to consume foods? Or would we expect low carbs, high protein, and high fat as the diet that should be consumed? The correct answer is A. The client is being discharged home. When providing client teaching, what will the nurse include as to when the client should seek emergency care? The client should be instructed to notify the healthcare provider if acute abdominal pain occurs and also if they experience jaundice, excuse me, those clay-colored stools or dark urine. Those are all going to be signs of biliary tract disease that may indicate complications if the disease progresses. A client with chronic cholecystitis reports pruritus, clay-colored stools, and voiding dark, frothy urine. Which lab analysis will be a priority in the nurse's assessment of this client? The correct answer is B. Excess circulating bilirubin will be present with chronic cholecystitis and is responsible for pruritus and changes in the stool and urine color. Cholecystitis is associated with several risks, including hepatic disease, pancreatitis, and peritonitis. Monitoring the liver function, the pancreatic lab values, and white blood cell counts are important, but they're not going to be the priority at this point. So which client is more likely to develop gallstones? Will it be the 45-year-old Caucasian female with a family history of gallstones? The 55-year-old African American male with a history of diabetes mellitus? The 62-year-old Hispanic Latino female with a history of irritable bowel syndrome? Or the 60-year-old obese American Indian female with a history of diabetes mellitus? The correct answer is D. Risk factors for developing gallstones include being female, being overweight, so obesity, a family history, diabetes mellitus, American Indian or Caucasian descent, a rapid change in the weight, advanced age. So the more the risk factors are present, the more likelihood of developing gallstones. So if you look at answer A, we have 2 risk factors, and in D we have 1, 2, 3, 4 risk factors. So D is going to be more likely. And last question. In the care of a client with acute pancreatitis, which assessment parameter requires immediate nursing intervention? Is it the heart rate of 105, the serum glucose of 136, the blood pressure of 102/76, or the respiratory rate of 28? The correct answer will be D. First of all, priority, we look at our ABCs. So respiratory rate is going to be right there. The heart rate would be our circulation. Blood pressure would also be circulation. So respiratory will be airway and or breathing. And we know that the client with pancreatitis can develop pulmonary complications. So it's really important to assess the respiratory status in the care of a client that has pancreatitis. We do know that clients may also be hyperglycemic and hypovolemic with pancreatitis, and it is important to assess those, but the immediate issue would be the respiratory rate.